Good afternoon. This is a presentation about prone ventilation for severe ARDS, acute respiratory distress syndrome patients in the intensive care unit setting. My name is Jessica Montanaro, and this is my graduate capstone project. Who are we? My institution is one of 8 hospitals in the New York City area, and this includes a teaching hospital for medical doctors. We are a closed 24-bed adult medical, surgical, trauma, and neuro ICU. We have a fairly large staff with 1 nurse manager, 4 assistant nursing care coordinators, which I am one of, and I help to oversee and run the critical care side of the unit of about 55 critical care nurses. Something unique to our institution that I have not found in every institution where I have worked, and I have not found happens based on my conversations with other critical care staff, is luckily our unit and institution places a very strong emphasis on interdisciplinary teamwork, including medical doctors, respiratory therapists, pharmacists, physical therapy, and critical care nurses. As a result, we were able to complete this project of prone positioning protocol for our patients, as well as tackle many others. The objectives for this capstone project and beyond for any critical care staff that wishes to learn about prone positioning for ARDS patients would be to recognize, examine, and define, which are all measurable outcomes and objectives. Our goal is to have staff recognize the pathophysiology of ARDS, salvage therapies used to treat it, and the literature that actually supports prone positioning as a frontline treatment. To examine and be able to report on the systematic approach used here and that was used to develop the manual prone policy for our institution, as well as the nursing driven and developed checklist, as well as to understand how to utilize the approach for other initiatives aside from prone positioning. And finally, to define the teamwork, the outcomes, and the challenges of the entire process. So before we get into the protocol development and training of critical care staff on prone, it's vital to have a good working knowledge of ARDS. Otherwise, the need for prone ventilation and the importance of it cannot be fully understood. Acute respiratory distress is not a primary diagnosis. ARDS is actually an acute inflammatory lung injury, which is always the result of some other underlying severe disease. There are several different causes of ARDS, which would be direct or indirect. Direct causes are primary lung injuries that injure the lung. So a patient might come in with pneumonia or aspiration of stomach contents. Perhaps they are mechanically ventilated for a long period of time, even blunt force trauma to the chest. Those would be the primary diagnosis of the patient, and subsequently ARDS, an acute inflammatory lung process and injury, then would be triggered by the initial event. Some indirect causes of ARDS would be lung injuries that occur in the setting of a systemic disorder like sepsis. Sepsis is a major indirect cause of ARDS. Other indirect causes would be pancreatitis, burns, and massive blood transfusions. Most importantly, the takeaway here is the extremely high mortality rate associated with ARDS. ARDS is deadly, and it does not discriminate against age or comorbidities. You can be 18 years old with no comorbidity, come into the hospital with either a direct or indirect primary diagnosis or injurious agent and progress to ARDS, or you can be 90 with multiple comorbidities and have a direct or indirect lung injury and progress to ARDS. And either way, you will be facing the same poor prognosis and the difficult, complex management of treating ARDS. Very few ARDS-specific managements have been shown to improve mortality. Mortality has been documented according to literature of about 40%. So of 100 people, 40 people will die diagnosed with ARDS. Some defining characteristics of ARDS, no matter where you work, what you will see is an acute onset of this profound hypoxemia. We call it acute because it develops within sometimes several days, sometimes several hours after some identifiable injury has occurred, either direct or indirect to the lung. Classically, you'll see bilateral opacities detected on chest x ray or CAT scan of the chest. And you have this respiratory failure, which is not fully explained by a cardiac component such as fluid overload. The PaO2 um, versus the FiO2, which is considered to be the PF ratio, um, is usually the defining characteristic of how severe ARDS is, right? So a PF ratio, anything above 3 to 400 is better. The higher the PF ratio, the better your respiratory status is. A PF ratio of about 200 to 300 would be considered mild ARDS, 100 to 200 moderate, and then anything less of 100 on a PF ratio would be considered severe ARDS, and this is gathered by an arterial blood gas. Here's just kind of a picture of the cascade of events that occur with ARDS. So you have your initial direct or indirect lung injury. For this sake, we'll just call it sepsis. Let's say a patient comes in, sepsis secondary to pneumonia. They then have this massive alveolar fluid overload and alveolar flooding. And at the alveolar site is the site of gas exchange. This inflammatory process then is activated, and neutrophils in abundance flood the site in response to this injurious agent. Between the neutrophil influx, the inflammatory cascade, and the alveolar flooding due to capillary leakage, there is a complete inability to oxygenate these patients. You will see patients on 100% FiO2, can't get much higher than that, with PEEPs on the ventilator, and PEEP is an intrinsic factor of your alveoli which help to keep them open so that gas exchange can take place. And mechanical ventilation, you can set PEEPs to much higher in order to assist this process. So patients will be on 100% FiO2, high PEEP levels, and their saturation for oxygenation will only be in the 80s. And this is very poor. And this is why we call it acute, because this process can develop extremely quickly after an injurious agent is identified. It can be minutes to hours, up to several days. What you're seeing here is a classic ARDS chest x-ray. This patient here actually was involved in a near drowning event. This would be considered a direct injury to the lung. And you can see the bilateral opacities classically defined here, which you will find on all ARDS patients. There's this pulmonary edema, right? These opacities in all four lobes, which we call a whiteout, without cardiac involvement, such as CHF or cardiomegaly. So what I'm defining for you here with the arrows is you have a very normal cardiac silhouette. You have a very normal diaphragmatic outline. So the pulmonary edema depicted here is unrelated to any cardiac event, and that's very classic of ARDS. It's this profound hypoxemia that cannot be explained. So understanding now how complex this disease process is, how difficult it is to manage, how really do we treat it? There has not been a lot of successful treatments documented for ARDS. You would expect that if a patient comes in with pneumonia, who is having respiratory difficulties and distress, if they've required mechanical ventilation, you would place them on a vent, start some antibiotics, give them supplemental oxygen, and the expectation would be that you see these patients improve clinically. And that is just not the case with ARDS. Once the ARDS cascade is triggered, these patients are unresponsive to traditional treatments. Therefore, specialized ventilator settings, all with the goal to decrease lung recruitment and increase oxygenation, are required. So the following have been documented in literature as salvage therapies. This is what we call them to treat ARDS patients. Specialized mechanical ventilation with lung protective strategies. And typically, that is low tidal volumes on the ventilator, high or low PEEP, which is still debated in literature. But the goal is to maintain an arterial saturation of oxygen between 88 and 89%, and then high oxygenation with the goal of titrating the FiO2 as low as possible as soon as possible. Other salvage therapies, and again, we call them salvage therapies because typically these treatments would incur a response in patients who are ill, but that's not the case, would be sedatives. We place ARDS patients in deep coma-like states. We place them on paralytics to decrease any further oxygenation or lung recruitment. Inhaled continuous vasodilators, or bronchodilators rather, are employed. And then ECMO is another treatment, which is oxygenation outside on a machine that bypasses the entire lung. And then finally, you have prone position ventilation, and that is the act of facing a patient in the down position on their stomachs. And this helps to improve rather the ventilation perfusion mismatch, transporting more oxygen into the bloodstream more efficiently. None of these salvage therapies mentioned here, except for prone positioning, has been documented or tested to show an improved oxygenation and affect mortality, except for prone. So, prone position ventilation works. Why is it not used? And why does this matter? Prone is the act of turning a patient down to increase ventilation and improve gas exchange. This is absolutely not a new concept in medicine. It's been around since the 1970s. However, in recent years, because of better studies and larger studies, prone is getting another look at again as being a frontline and effective salvage therapy. Often it was used for severe ARDS, but as time has gone on and medicine has brought us different evidence-based practices, prone was put to the background while other measures have come to the forefront. However, they have not been shown to improve mortality. Therefore, prone is being brought back. Prone can be accomplished either using a device like a rotaprone bed or completed manually with the staff. Everything moving forward in this PowerPoint presentation, when I refer to prone position, I am referring to the manual proning of patients using the physical labor of staff. And finally, prone saves lives. It absolutely has been documented to improve mortality by 16% in this subset of patients. Prone, however, is considered to be a very high-risk, underutilized procedure. Risks associated with prone positioning would be loss of airway, loss of central lines, risk of coding, because these patients are critically ill, so they can code while in the proning process or once prone has been completed. Prone, in a prone patient, these patients are often, once placed on their stomachs, how prone works is that it decreases the organ compression within the thoracic cavity. So all the organs that compress internally inside the thoracic cavity in the supine position, that pressure is relieved when the patient is in prone. Additionally, prone position shifts pleural pressures, decreasing the dorsal lung pressure, allowing for more recruitable lung to be available to oxygenate. Also, at the same time, shifting and decreasing dorsal lung atelectasis, which is classically found in ARDS patients. I mentioned here the New England Journal of Medicine PROSEVA trial. This was done in 2013, and this is the largest study done in Europe across 27 ICUs with about 500 patients in the study. Two groups were tested, one all with ARDS. One group was left in the supine position. The other groups were turned actually in the prone position. There was a 28-day mortality endpoint. And this study which is largely referenced when prone is being discussed, demonstrated that prone positioning above any other salvage therapy actually absolutely decreases mortality by up to 16%. I also mentioned here the lung safe study, which is a much larger study done than the Perceiva trial. And this was actually tested 459 ICUs across 50 countries, which also showed that prone position works. However, this study actually showed that prone positioning is vastly underutilized despite evidence that it works. And this was largely due to the high risk factors and the barriers associated to proning severe ARDS patients. That brings us exactly to our problem in our ICU and the basis of my capstone project. A needs assessment was conducted in our ICU. We have a large population of ARDS patients, and despite the use of salvage therapies in our intensive care unit, we were unable to save these patients, and it was extremely complex and frustrating for all critical care staff. We knew based on literature that prone positioning worked and had evidence supporting it that it decreased mortality, but quickly realized that not one hospital within our entire hospital system had a prone protocol or a policy in place, nor the education to support the critical care staff throughout the process. So we decided to create one. We decided it was necessary to have a prone ventilation protocol for our ARDS patients. And we decided that we were going to create, as first step, a work group. The nursing theory that supports this project, this capstone project best, and really was used as a guide, is Patricia Benner's novice to expert concept nursing theory. We believe that, as well as what her theory suggests, that we are all in these cycles between novice and expert phases throughout our careers. And to summarize Pat Benner's theory, really it's that nurses pass through 5 stages of skill acquisition, from novice, who are considered beginners without experience in a specific situation, problem, or task that they are being expected to carry out. And in this case, that would be the prone positioning of a severe ARDS ICU patient. And the belief is that a nurse who has, no experience at all with that skill or the knowledge, and then you move through stages up to the expert expert level rather, and that is really a nurse who has enormous experience as well as an intuitive grasp of the situation or the problem, really without any wasteful consideration. And at that place, at that phase, can even offer alternative diagnoses or interventions. But at each stage, from novice, beginner, competent, proficient, and expert, there is a newly acquired skill, really, as the nurse is exposed to more meaningful situational experiences. So, as I developed this protocol through extensive literature research, learning, testing, through in situ simulation, modifying, re educating myself, practicing, and then being able to teach it, I became the expert on this subject matter, enough to educate other critical care staff. And as I passed through these stages from novice in this area, having no experience with prone, really what risks were associated with it, what could go wrong, how to carry it out safely, how to manage these types of patients. I acquired new skills that I was able to pass on to the critical care staff. And this is really also true for our critical care staff because while they're experienced ICU Staff members, and I'm talking about doctors, ICU attendings, residents, respiratory therapists, critical care nurses. I would have to say the about 95% of the staff that was exposed to this in our unit, to this project, had absolutely no experience with manually prone positioning a patient in the most detailed, structured way that I had developed to carry it out. Uh, Experience had come through with using a rotoprone bed, which is very different than the manual prone positioning of a patient. So essentially, the critical care staff at this juncture were all novices without any experience, if you will, at all with this type of management or how to carry it out. And through training and in situ simulation, I would say at the end, based on measured outcomes and surveys, all of them came to a competent level and some even to a proficient level. So, this really is the theory that we felt supported our growth and skills acquisition. So, we started our work group, our interdisciplinary work group, uh, and we made the foundation of this entire capstone process an interdisciplinary foundation with collaborative um, input at all times. Uh, we we did extensive literature review, and based on that, manual prone positioning was chosen as the method, uh, based on experience and based on economics. That would be the type of prone protocol that we would use. A critical decision was made here to use a live ICU clinician for testing of the protocol rather than a mannequin, which allowed for more real time feedback and helped us to rapidly and easily develop the protocol steps. For example, when a patient is placed in the prone position, according to literature, it is suggested to place the patient in slight reverse Trendelenburg. Initially, I wrote in that 30 degrees would be an appropriate height for reverse Trendelenburg. However, during live in situ simulation with a live ICU clinician, the simulated, if you will, patient was able to provide feedback that they felt that during the turning process while rotating the head with that high of a degree of reverse Trendelenburg, that actually hyperextended their neck and it was uncomfortable. That is the real-time feedback method that allowed us to adjust the protocol that a mannequin would not have been able to give us. Real-time feedback as a method for rapidly progressing the protocol absolutely was an integral decision made that I have not found in literature when it comes to prone positioning. Here is a picture of our very first in situ simulation session. And what I'd like you to pay attention to here in detail is the interdisciplinary approach and group that I gathered. At the head of the bed, you have two respiratory therapists, one dedicated solely for turning the head, one dedicated just to protect the airway. You can see identified through arrows the ICU nurses. There are 4 ICU turn nurses and 1 ICU nurse dedicated just to protect all the central lines the patient has. You have a medical doctor. We wrote in a medical doctor as a leader as well as an RN as a leader for the protocol. And pay close attention to the patient in the bed. That is not a mannequin. That is one of our ICU residents who agreed to help me with this project and play the simulated patient. And this was a fully simulated session. So you can see there full patient preparation. He has the foam pads. He has simulated intubation, eyes taped shut. He did a wonderful job and actually was able to stop and provide us feedback as we tested the protocol. This is just another picture of the same exact protocol that we were testing that day. This is our first in situ simulation. And it was actually, I showed this picture because the doctor at the head of the bed in the blue holding the protocol that was written was calling out to me parts of the protocol that I had written and asking me questions such as, Nurse Jessica, were the tube feeds held? Nurse Jessica, was the chest tube drained? And so on and so forth. And all of that was expected to be done prior to gathering the team and proning the patient. I quickly realized that this could become a high stress situation, and there was a lot of equipment, room, and patient setup required to accomplish safely. So I decided to develop a nursing checklist which mirrored the protocol exactly. However, separating it into sections, such as equipment needed with checkboxes, patient prep needed with checkboxes, orders pre, intra, and post needed prone with checkboxes, even step by step guidance through on how to turn the patient into the prone position was written in, and that was based off of this first in situ simulation. Here is a picture of our second in situ simulation, and I'd like to bring your attention to actually the great amount of attention that we paid to detail. If you see here, fully simulated live clinician, that's actually our medical director who agreed to help me with this project. And you can see what we're practicing here is how to protect the airway at all times when turning the patient, and eventually practicing what position would be most comfortable for the staff to care for as well as for the patient to be in. And at all times, if something did not feel right to the patient, the simulated patient would stop, tell us what they thought did not or did work in the protocol. We would adjust the protocol on the spot and go back and rewrite it in. So, what were the goals of simulation for training for the staff? Once the protocol was fully developed and we had 2 in situ simulations with real time feedback. So, once all of that was evaluated and the protocol was fully developed, overall goals of simulation were created and outlined for the actual training of critical care staff. Um, and they were to improve interdisciplinary team communication, review setup of proning for proning ventilation, actual proning process, and the return to supine positioning. Learn how to manage the medical code while in the prone position and requiring emergent supine of the patient. And finally, pre and post test surveys performed to assess confidence and knowledge. And these were the goals outlined of the simulation training for staff. What you're looking at here are pictures of the simulation education sessions for the capstone project, and this was conducted after the 2 in situ simulations were done to test the protocol. We realized we could not use a live clinician for the training because there would be a lot of turning back and forth. Really, the live clinician was only used to test the protocol. But for the actual training project for the capstone, I decided to use a 3G high fidelity simulated mannequin, which was hooked up to an actual ventilator. And you can see that here what we're doing is promoting standardization and safety without harm to the patient. We're training staff in novice roles who've never had experience or been exposed to proning a critically ill, ventilated, severe ARDS patient in the simulation lab in a very safe way, promoting complete standardization by adhering to the protocol and the nursing developed checklist each and every time. So the first picture is the high fidelity SimMan, which we not only had full setup, we had simulated intubation, simulated central lines, Foley catheters, etc. The middle and the end pictures are group shots of an interdisciplinary team that I trained for the capstone project of doctors, ICU attendings and residents, as well as ICU nurses and respiratory therapists. And they're learning how to prone and then again what to do in an emergency situation when the patient is in the prone position. So what you're seeing here is the completed nursing protocol, fully developed and being taught safely with deliberate um, practice and feedback. Rapid cycle debrief with deliberate practice was used as a method to promote on the spot learning and correction of errors. Um, it was also changing of the roles frequently that helped each discipline to appreciate the role of other disciplines in the prone turning process and management. And we found that through the simulation process, um, it worked best when the entire procedure was run by a nurse. So here are some conclusions of the simulation training. Rapid cycle debriefing with frequent changing of roles supported interdisciplinary respect and communication. Feedback from the session that I led also led to improvements in the protocol. Nurses and doctors had some suggestions while in the simulation training lab that actually worked better for the protocol, and I'm going to show you one of those on the next slide. We found that a nurse leader directing the step by step process worked much better than allowing a medical doctor to run the process. We also I found that respiratory therapy, directing and leading every movement of the patient uh, was most appropriate because they were the ones securing and managing the airway at all times. And then finally, the interdisciplinary collaboration led to something called like new signage for the patient. One of the critical care attendings, when we were working on the emergency turnback situation, we found that there was a lot of crosstalk and chaos among the staff because it was a high stress, high risk, underutilized procedure now in an emergency. So one of the doctors came up with, once the patient is in prone position, rather than having a discussion about which way to turn the patient back in an emergency situation only, whichever way the patient's nose was facing would be the start of the direction to resupine the patient. And we calls this the nose. And this became an easy way for everyone to remember which way the patient needed to be turned only in an emergency situation. In a planned supine of a prone patient on a regular basis, the supine turning would actually be planned out because there are, in fact, central lines, IV lines, and ventilator tubing that need to be considered when turning the patient back. But in an emergency situation, this actually was an unintended, I would say, development during the simulation training, which actually benefited the protocol wonderfully. Here's an example of the sign that was developed or suggested and then developed by myself and the group while the patient was in an emergency situation, the nose, and we actually hang this over the head of the bed of an ARDS patient who is in the prone position to remind all staff in an emergency, again, taking the thinking out of a stressful situation. Okay, so results of our my quality improvement capstone simulation project. I completed one session for my capstone project. We have 10 more planned moving forward. The session was 4 hours long. That's 240 minutes. I was able to train 20 staff members with a goal for training in the future beyond capstone, all critical care staff. But currently, I train 6 medical doctors, 4 respiratory therapists, and 10 nurses, critical care nurses. The survey results showed that there was absolutely a significant increase in the comfort in prone positioning a patient. There was absolutely a significant increase in the confidence in proning a patient, an ARDS patient. But there was no significant change in medical knowledge of ARDS. Most of the critical care staff felt that they understood, had a good working knowledge of ARDS pre and post proning. I found that the average time during my one session to return a patient to the supine position to start CPR was about 63 seconds, but the range was 23 to 133 seconds. And that probably accounted for the emergency situation was a complete surprise to the staff. once I had taken them through the very controlled learning simulated prone positioning training, once the patient, again the 3G high fidelity mannequin, was in the prone position, I switched the monitors to VTAC or some kind of lethal rhythm, waited for the staff to recognize the rhythm, allowed them to go through an emergency turn back without training them, again using the rapid cycle on the spot feedback and debriefing for training, and then again going through a simulated controlled return of a prone patient to supine in an emergency situation. That is where the variance comes in from 23 to 33 seconds. But once the training was completed, the average time to supining a patient in an emergency was 63 seconds. And again, to our knowledge, this really was the first implementation of the prone protocol using not only simulation, but also the first time that simulation training has been used for an interprofessional team in prone literature. And I have not found any literature that talked about supining or dealing with an emergency situation. The capstone project developed was comprehensive, well received by stakeholders in our organization, which is the organization itself, because we became leaders of our larger hospital institution to pioneer a very important protocol that's needed across our entire hospital system, as well as the stakeholders being the critical care staff who were desperately looking for a way to provide best practice and more quality care for our ARDS patients. The critical care staff, including nurses, doctors, and respiratory therapists. So, as a result, I was asked to train the critical care staff in charge of the simulation lab at our sister hospital so that they can assist us with further prone positioning education and training so that we can capture all staff at both our two main hospital sites. And here's a picture of me, the ICU nurse, and I'm actually training a nurse manager who is in charge of the simulation lab, several ICU doctors and attendings who are not only heads of the ICU department, but as well as head of the simulation lab and the respiratory therapist of the sim lab, teaching them the protocol that I developed, teaching them an insight to, if you will, simulation. We went through the whole thing so that they could help train critical care staff moving forward. And that's how my organization plans on carrying this out beyond the capstone project. And it has greatly impacted our institution. So this is actually a real patient. There are no patient identifiers in these pictes that required prone positioning just after the prone protocol was developed. So we had a patient. She was a 70-year-old female, in her 70s rather. She came in with influenza A, streptococcal pneumonia, and she had a little bit of a course with us, progressed to ARDS, and despite all salvage therapies being employed, and by that I mean she was on many sedatives with a deep coma-induced state. She was on paralytics, inhaled bronchodilators continuously, and 100% FiO2. It was a Sunday evening, and she was saturating only in the 70s. Our only option at that point was to ambu bag her, but we knew that she was going to die. I had just developed this protocol. I had just gone through some training with the staff. And there was actually a decision made to use the protocol to prone her as an effort, although not fully developed, because we knew we had no other options to save her life. So using the protocol developed, using the nursing developed checklist, which wound up being the absolute cornerstone to carrying this out safely, this patient was able to be proned successfully without any adverse outcomes. She sustained prone for 16 hours and actually survived her course of ARDS. Still with us, however, absolutely surviving her course of ARDS, which probably was not possible that night. So that's an absolute huge accomplishment based on this capstone project and protocol developed. I thought I would add in some lab values just to show you the benefits of prone positioning. You can see here the The yellow line indicates the PCO2 on an arterial blood gas, and the red line is the PaO2 on an arterial blood gas. And the goal is always to have your PaO2, which is your partial pressure of oxygen in your arteries, high, right? That indicates good oxygenation. 45 is extremely low. The patient, in her most acute ARDS state, had dropped her PaO2 to 45. We made that decision to use the newly developed prone protocol and nursing developed checklist to prone the patient. Patient was prone, and at that point you can see her PaO2 in the prone position goes way up dramatically, which allowed us to decrease her PEEP, which is good, as well as her FiO2, which is fantastic. So we were able to move around on her ventilator settings, unable to do that prior to. And although her PaO2 dropped down a bit, which is expected, you can see that it never went back down to 45, and it sustained. So that is absolutely progress and um, uh, very good things as a result of this. So what are outcomes of the overall project? Overall outcomes of this entire capstone project was that I have found earlier identification of ARDS by clinical staff now that awareness have been raised. As a result of the protocol developed in the nursing-driven checklist for prone positioning, we now have a systematic and organized approach to interventions for ARDS patients. We have better and early preparation for prone according to the checklist and protocol. So now when nurses identify that a patient is going into an ARDS cascade event, they're already instructing the residents, hey, let's put a central line in, make sure it's sutured. Let's put an A line in, make sure it's sutured. Just preparing things that we know we would need to prone the patient. There's an overall absolute improved confidence of the staff, all critical care staff, and that's from physicians, nurses, respiratory therapists. There's improved skill, and again, that speaks to the Benner's, novice to expert theory in nursing. Not one critical care staff member that I trained had been exposed to prone positioning, except for a rotaprone bed, which was not. Okay, much more detailed, much more to this for manual prone positioning. So all of us were considered novices at the beginning. However, there was improved documented skill of critical care staff in accomplishing prone ventilation and even the management of an ARDS patient, which moved us up through the 5 stages, not completely all the way to the top. Those of us who use it more frequently and have been immersed in this project can be considered proficient. However, competent is a great level to achieve with this. And then finally, this has led to prompt recognition of an emergency as well as initiation of critical action. So now when a patient's in the prone position, if an emergency were to occur, critical care staff have that signage, the nose knows, and they know exactly what they have to do to get that patient back supine in order to start CPR and save their life. Thank you for taking the time to listen to my project.